Let's talk about managing side effects of tamoxifen and aromatase inhibitor. Side effects common to both tamoxifen and AIs, hot flashes. 80% of patients taking tamoxifen can experience hot flashes. Sexual dysfunction, cognitive function decline, sleep disturbances, and hair loss. For hot flashes, premenopausal women have a greater increase in hot flashes after tamoxifen. For these patients, usually SSRI, SSRI and SNRIs are first line. However, some of them are strong CYP2D6 inhibitors and can affect efficacy of tamoxifen. So they should be, these are theoretical. However, it should be, we should try to avoid these medications such as paroxetine and fluoxetine. Venlafaxine is widely studied. We can start them at 37.5 milligrams per day and increase weekly if needed to 150 milligrams per day. Citalopram can be also used and is better tolerated than venlafaxine. We can start at 10 milligram daily and increase it to 20 milligram per day after 1 week. AI has less vasomotor effects. Sexual dysfunction, non-hormonal options such as lubricants and moisturizers should be first line. Vaginal moisturizers for 3 months improve symptom in 90% of patients. They should be using 3 to 5 times a week. If the patient completed a full course of adjuvant endocrine therapy or the breast cancer is hormone receptor negative, we can consider low dose vaginal estrogen or vaginal DHEA such as progesterone. However, we should consult with the oncologist before starting them on these medication. For hair loss, we can use topical mineral minoxidil. Specifically for tamoxifen, there's a 2 times risk for VTEs. Some of the modifiable risk factors is obesity, smoking, and hypertension. If the patient has a family history of clots, we should obtain genetic workup on the patient because if the patient is factor V Leiden mutation heterozygous, their risk of VTE is 5 times than someone who is not. Personal history of clots, obviously they should avoid tamoxifen. Tamoxifen should be stopped prior to surgery. After 3 weeks, the level of tamoxifen in the body is decreased by 90%. Uterine bleeding, hyperplasia, or cancer. Some of the rates: 5-year endometrial cancer rate for a postmenopausal woman on tamoxifen is 3 out of 1,000 versus less than 1 out of 1,000 in general population. For premenopausal patients, they are only at baseline risk. In postmenopausal women after 4 years of tamoxifen, 10% of patients have simple hyperplasia, 3% have atypia, and 2% will have cancer. Even without atypia, postmenopausal women with hyperplasia on tamoxifen should be offered hysterectomy. Progestin PO is contraindicated due to risk of endometrial cancer. Mirena IUDs or levonorgestrone containing IUDs. The data on these are limited on tamoxifen users. 20 out of 1,000 women on tamoxifen can develop polyps, and 10% and in postmenopausal women these can be up to 10% after 4 years. They tend to be large, greater than 2 centimeters, and 5% malignancy rate. In general population, risk of malignant polyp is 5% in postmenopausal and 2% in premenopausal. So it's about the same then. On premenopausal patients, 50% will have AUB, while on tamoxifen, 20% of AUB will have an underlying endometrial pathology. Polyps are the most common. For postmenopausal women on tamoxifen, 25% will have abnormal uterine bleeding. To evaluate these patients, first we have to establish their menopause status. Patient with amenorrhea on tamoxifen could be premenopausal. We can obtain FSH and E2 during tamoxifen use. They're still reliable. Tamoxifen does slightly raise FSH levels, but not to postmenopausal levels. So FSH greater than or equal to 70 IU per liter. These are consistent with menopause. If the FSH is between 25 and 70, we'll have to look at their E2 level. If the E2 is less than 20 picogram per ml, then they're menopausal. If they're greater than 20, greater or equal to 20, they're perimenopausal. If the FSH is less than 25 IU per liter, and the E2 is greater than or equal to 20, they're premenopausal. And if their E2 is less than 20, they're perimenopausal. Postmenopausal women, we should evaluate them with EMB and ultrasound. If the biopsy is normal, the ultrasound suggests a focal pathology, then we should do a hysteroscopy. If the ultrasound shows thin endometrium less than or equal to 4 millimeter, we can manage expectantly. And assuming the biopsy is normal. Premenopausal, new onset of amenorrhea or oligo is common after starting tamoxifen. These patients we can expectantly manage unless the patient already has oligomenorrhea prior to starting. This could be due to ovulatory dysfunction and should be investigated further. Heavy bleeding or intermenstrual bleeding, these patients should obtain an EMB and ultrasound to evaluate possible focal pathology. Endometrial thickness is not helpful in premenopausal women. Hysteroscopy if recurring bleeding or ultrasound shows possible focal pathology. We can also do sonohysterogram on these patients. Incidental findings, if there's a polyp, they should be managed as a symptomatic patient. Tamoxifen can cause cystic changes in the endometrium. If there's no bleeding, it does not require further evaluation. These patients can also have eye problems. Ocular exam is recommended if the patient is complaining of any new visual symptoms. And fatty liver disease, usually clinically not significant. And they're not routinely we do not routinely monitor liver function. However, if the liver function is greater than 2 of the normal limit, tamoxifen should be stopped. Some other information with tamoxifen. Rate of endometrial cancer 1.5 per 1,000 patient years versus 0.5 per 1,000 patient years in placebo. So the relative risk is about 2.5. Risk is mostly in patients greater than age of 50. Rate of uterine sarcoma on tamoxifen is 20 out of 100,000 patient years versus none in placebo. Screening postmenopausal patients with transvaginal ultrasound and a sonohysterogram to rule out uterine pathology before starting tamoxifen can be helpful, as these patients are more likely to develop since patients with prior uterine pathologies are more likely to develop endometrial cancer. Let's see a little bit more about treating urogenital symptoms in patients with history of estrogen dependent breast cancer. Epidemiology. So genital urinary syndrome of menopause, GSM, includes genital dryness, burning, irritation, dyspareunia, urgency, dysuria, and recurrent UTIs. 250,000 new invasive breast cancers are diagnosed each year in the US. 80% are estrogen receptor positive, 60% progesterone receptor positive. The median age at diagnosis is 62, 30% are less than 50 years old, and 10% is less than 40 years old. Endocrine therapy, usually premenopause. It's at least 5 years of tamoxifen, and postmenopausal woman is 10 years of AI. Consensus recommendation and discussion. Oh yeah, table 1 is all the table 1 has all the different pharmacologic information. So non-hormone approaches, we can use polyacrylic acid or hyaluronic acid lubricants. These are more effective. We use 3 to 5 times a day. Vitamin D and vitamin E suppositories. You can also use 4% aqueous lidocaine 3 minutes prior to intercourse for dyspareunia. Hormone hormone therapy formulation associated with serum estradiol level of less than 20 picograms per milliliter or 4 micrograms of estradiol insert, 7.5 microgram of estradiol ring, 10 microgram of estradiol insert or tablet. AI does not block the effects of exogenous estrogens on breast tissue due to its mechanism of action, because it only prevent the aromatization of the androgens into estrogen. So if you give estrogen by itself, it's already there. So use of vaginal estradiol has not been shown to affect breast cancer recurrence in patients taking AIs. Vaginal DHEA 6.5 milligram daily inserts. Estrogen concentration in women taking AI has not shown to change. Vaginal testosterone in patients taking AI can be helpful as well. Aspenafine should not be used in patients with breast cancer on product label. However, studies have shown that the antigen its actually antagonist effect on breast cancer. There is no case of endometrial cancer or atypical hyperplasia observed after 52 weeks of treatment. Laser therapy is not FDA approved at this time, and more data needs to be researched.